the glass shatters on the kitchen tile. Not a cup, a window. Your child's arm is a bright red fountain, and you move on instinct, grabbing the black tourniquet from your kit. You wrap the strap around a limb no thicker than a rolling pin. You crank the windlass. The strap bunches. The slack won't die. The blood doesn't stop. The tool that works on your thigh just failed on the smallest arm in the house. Most people train for adult trauma and assume the gear scale's down. It doesn't. Subscribe so you never miss this. Stay for number 6. The improvised windlass that might be the only thing that fits when the commercial kit bottoms out. Item 1. The manual direct pressure fist. Forget the strap. Forget the strap. Forget the windlass. On a child, your body is the tool. Make a fist. Place it directly over the wound. Knuckles driven into the source of the bleeding. Lock your elbow and lean your full adult weight into that single point of pressure. A child's blood pressure is lower than yours. Their vessel walls are more elastic. Your focused body weight can occlude a brachial or femoral artery that a fumbling tourniquet might miss. Do not lift the fist to peak. Do not shift to relieve the pain. The child will scream. The screaming means blood is still reaching the brain. Hold the fist for 10 full minutes if necessary. Most parents will wrap a thin bandage and keep lifting it to check, restarting the clock every time. You will drill a fist into the wound and hold it like a hydraulic press. Direct pressure fails on adults with massive arterial pressure. On a child, it wins far more often than the tactical industry admits. The fist requires no gear, no sizing, no windlass. It is always the right diameter. Use it first. Item 2. The improvised pediatric tourniquet, cravat and handle. If direct pressure fails and bright red blood still pulses, you need a windlass device that fits. A standard cat tourniquet often bottoms out on limbs less than 5 inches in circumference. The strap can't cinch tight enough because the windlass runs out of travel. Your alternative is a folded triangular bandage, a strip of torn bedsheet, or a wide cloth belt. Width is critical, 2 inches minimum to prevent tissue damage. Wrap it high and tight on the limb, as close to the armpit or groin as anatomy allows. Tie a half knot. Place a rigid object on top, a wooden spoon, a metal hairbrush handle, a thick marker. Tie a full knot over it. Twist the windlass until the bright red flow stops completely. Then tie the handle in place and mark the time on the child's forehead with a pen. The softer fabric conforms to the cone-shaped taper of a child's limb better than a flat nylon strap. Most people have never practiced with anything but a commercial tourniquet. You will practice this tonight with a cloth strip and a spoon on a rolled-up towel, the circumference of your child's arm. When the commercial tool bottoms out, the improvised one is already in your hands. Item 3. The junctional pressure wedge, groin and armpit. Some wounds are too high. The bleeding comes from the crease of the groin or deep in the armpit where no tourniquet can reach. This is junctional hemorrhage. On an adult, you pack it with hemostatic gauze and pray. On a child, the anatomy is smaller and more compressible. Take a rolled sock, a tennis ball, or a tight wad of gauze. Shove it directly into the groin crease or the armpit over the pulse point. Press it in hard with your hand. Then take an elastic bandage, a torn sheet, or a wide belt, and wrap it over the wedge as tight as you can physically pull it. The wrap locks the wedge down. The wedge transmits pressure directly into the deep artery against the pelvic bone or the shoulder joint. For a child, the pelvis is still cartilaginous and more yielding. The shoulder is narrow. The wedge technique works faster and more reliably on small anatomy than on a thick adult torso. Most people have never heard of junctional packing. For a child, you will remember the sock and the elastic wrap. A tennis ball costs $1. It fits the armpit of a 6-year-old perfectly. Physics doesn't care about age. Pressure into bone stops the bleed. Item 4. The tight compression wrap. Elastic bandage and gauze. Not every pediatric bleed needs a tourniquet. Some need a pressure dressing built in layers, applied with a tension that would be excessive on an adult, but is exactly right for a small limb. Take rolled gauze. Pack the wound directly if it's a deep cavity. Feed it in with your finger until the cavity is full and firm. Then layer folded gauze pads over the packed wound. Now take an elastic bandage, an ace wrap, or a strip of torn elastic from a clothing item. Begin wrapping directly over the gauze pillow. Pull the elastic tight, tighter than feels comfortable. The goal is to create uniform compression that presses the packed gauze down into the vessel. On a child's slender arm or leg, a tight elastic wrap can generate enough radial force to stop arterial flow without the focal crush injury a windlass creates. Wrap distal to proximal, overlapping by half, and pin it in place. Most people apply a loose bandage and call it a pressure dressing. that does nothing. A true compression wrap on a child should visibly indent the limb, and you should not be able to slide a finger under it. The elastic adapts as the limb swells. The gauze conforms to the wound bed. Together, they achieve what a poorly sized tourniquet cannot. Item 5. The emptied blood bladder. Dialing back the clock. A child's total blood volume is vanishingly small. A toddler has roughly 80 milliliters of blood per kilogram of body weight. A 25-pound child carries less than 1 liter total. An infant less than a soda can. The math is brutal. A wound that pulses bright red can drain a child's entire blood volume onto the floor in under 2 minutes. You must know when to escalate from direct pressure to a windlass device based on visible loss, not on protocol. If the blood pools wider than a dinner plate, you are past the threshold. Do not wait to see if the pressure holds. Go immediately to the improvised tourniquet or the junctional wedge. Most parents hesitate because they fear the tourniquet will cause damage, waiting too long and letting the child slip into irreversible shock. A tourniquet on for under 2 hours rarely causes permanent nerve or muscle damage. Exsanguination is permanent in under 3 minutes. The choice is not ambiguous. The blood bladder is emptying. The clock runs faster on a child than on any adult you've ever treated. Recognize the pool. Call the escalation. Move. Item 6. The parental freeze override. The psychological tourniquet. The child is screaming. The blood is everywhere. Your hands are shaking so violently, you cannot thread the windlass. This is not weakness. This is the limbic system hijacking the motor cortex of a parent watching their child bleed. The most lethal failure in pediatric hemorrhage is not the gear. It is the freeze. The pre-rehearsed script is the only antidote. You will say out loud, "Now, in the calm light of day, I am putting pressure on the wound. I am saving your life. It is okay to scream." Drill the words. Drill the movements on a doll, on a rolled towel, on your own leg in a simulated high-stress scenario. The voice that speaks the script overrides the internal scream. Most people have never said the words out loud, and when the moment comes, their throat closes and their hands stop. You will have the script locked in your temporal lobe next to the motor sequence for the fist, the wrap, the wedge. The child will scream. That means they are alive and perfusing their brain. Your voice answers their scream with a steady, repetitive loop. I am helping you. I am stopping the blood. Stay with me. The psychological tourniquet is not metaphorical. It is the preloaded neural pathway that fires when the conscious mind disintegrates from shock. Train it now. It will run on its own when you cannot think anymore. Here is the reality that the tactical medical industry will never print on a commercial tourniquet package. The standard CAT, the Sophie, the flat nylon windlass devices were built for the thigh of a soldier, not the arm of a 3-year-old. On a limb smaller than 5 inches around, the strap bunches, the windlass bottoms out against its own clip, and the deep artery escapes compression against the bone. The tool doesn't just fail. It fails while you are watching it, expecting it to save a life, and the blood keeps pulsing. Most people carry an adult tourniquet and assume they are prepared for every member of their family. They are not. They are carrying a false confidence that bleeds out in real time on the kitchen floor. Your primary tools for a child are not a strap and a windlass. They are a fist driven by body weight, a folded triangular bandage with a wooden spoon, a sock weighted into a junctional crease and locked down with an elastic wrap, a layered compression bandage pulled tight, and the voice that rehearsed the script before the glass ever broke. A child's total blood volume fits in a 2-liter bottle if they are lucky. A toddler holds less than a liter. The clock does not stretch. The escalation from direct pressure to an improvised windlass to junctional packing must happen in seconds, not minutes. The parent who hesitates, who lifts the bandage to peak, who waits too long because the commercial tool feels like the only legitimate option, loses a fight that was winnable with a strip of bedsheet and a hairbrush handle. Now drop a comment and tell me this. Walk into your child's room tonight. Look at the size of their arm, the circumference of their thigh. What is the object in your house right now that you would use as a windlass if your commercial tourniquet bottoms out? A spoon, a marker, a flashlight. Name it in the comments. Then go put it in your medical kit. And in the next video, we are building the pediatric trauma kit that the industry refuses to sell. The gauze, the wraps, the improvised tools that cost under $10 and actually fit the smallest members of your family. I'll see you there.